Evening and a warm welcome to all the dignitaries present here. I'm Sreushi from Clanet, serving as the allocated session assistant to ensure a seamless experience. Clanet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clanet serves as the digital partner for this event, and the focus of today's session is anesthesia machine. So let's begin today's session, for which I would like to invite Dr.AL.Meenakshi sir to take over. Sir holds degrees in MBBS, DA, MD Administration, Dean and DME in Government Medical College, Professor of Anesthesiology, Thanjavur and Tirunelveli Medical College, National Vice President of Indian Society of Anesthesiologists 2016, National Governing Council member of Indian Society of Anesthesiologists 2009 to 12, President of ISA Tamil Nadu State Branch 2011 to 12, State Secretary of Indian Society of Anesthesiologists Tamil Nadu State Branch 2006 to 10. So without any much delay, sir, now I would like to hand over this session to you. Over to you, sir.
Thank you, Clarinet. At the outset, I request the City Branch President, Dr. Munian, to offer the presidential address. President, sir. I request Dr. Kannan to offer his secretary address.
Good evening all. Successfully we are conducting 12th webinar of second edition of Puthukkotai today. Today our topic is anesthesia machine, which is very important and basic topic to all postgraduates and practicing anesthesiologists. Last week, 11th webinar of second edition of Puthukkotai conducted on 2nd April. The topic was anesthetic management in ENT surgeries. We have divided the topic into 3 subtopics. First one is innervation of larynx, and second one is anesthesia for post-tonsillectomy bleeding, and third one is anesthesia for CO2 laser surgeries in ENT. The moderator was Dr. Jerry Paul, Professor of Anesthesia, Amrita Institute of Medical Sciences, Kochi, Kerala. First subtopic, innervation of larynx, was done by Dr. Arul Prakasam. He is postgraduate, Kanyakumari Medical College, Nagarkoil, Tamil Nadu. He has elaborated the innervation of larynx. He was started with anatomy of larynx, complete explanation, and the blood supply of larynx. He has divided the innervation into 2, sensory innervation and motor innervation with flowcharts. He described with many anatomical pictures clearly. And the second subtopic is anesthesia for post-tonsillectomy bleeding, which was done by Dr. Rekha. She is consultant anesthesiologist in Kochi, Kerala. She has highlighted specific problems in the case of anesthesia posted for post-tonsillectomy bleeding and assessment of hypovolemia in children and immediate management of this case in the ward. She has explained blood supply of tonsils very clearly. She has explained complications which we can expect in a post-tonsillectomy bleeding. First one is the case is sad airway. Second, general anesthesia. There is residual narcotics. And third, the potential difficult intubation. And fourth one is the risk of pulmonary aspiration. And fifth one is potential hypovolemia. She has explained the signs we can evaluate, how to assess hypovolemia in children in this case, which she has described signs of cardiovascular system, skin, cerebral signs, and renal signs, respiratory signs also. She has explained the OT preparation, which the instruments we needed in the emergency case. And the third subtopic is anesthesia for carbon dioxide laser surgery in ENT. Sir has explained different types of laser and properties of laser light. And here he has explained pre-operative assessment and anesthesia management for carbon dioxide laser surgery. Pre-operative assessment, which included detailed history of case, cardiovascular and respiratory systems examination, and he has explained airway fires protocol. Sir has explained the images, which included vocal cord nodules, carcinoma vocal cord, and laryngeal web. And we need your kind support to continue this academic program. Last webinar, 946 delegates have attended. We are very much thankful to our academic chairman, Dr. Meenakshi Sundaram sir. Thank you, sir, for your continuous support. Our aim is to reach 1,000 delegates to attend the upcoming webinars. We are having the consistency and quality in the webinars, which is very useful to postgraduates. Postgraduates kindly attend the academic programs continuously, which will help you in exam very well. Thank you, sir. Thank you.
Thank you. Dr. Munian, Presidential Address.
Good evening, sir. I am Dr. K. Munian, President IASA Puthukkotai City Branch. On behalf of IASA Puthukkotai City Branch, I welcome all the speakers. It's my honor to welcome you all for the online webinar conducted by the IASA City Branch in the name of Puthukkotai, Bhudan. Today we are conducting 12th episode of second editions. Today we are going to discuss about the topic of anesthesia machines, and it's a subtopics like laryngoscope and video laryngoscoping and low flow anesthesia and anesthesia safety measurement. I would likely focus on the anesthesia machines in modern medicine, their evolution over time, and the latest advancement in technology. The key components of anesthesia machines, it includes gas supply system. This components provides gas supply like oxygen, nitrous oxide, and air from the central system to the anesthesia machines, and the vaporizer. And second one is vaporizer. And the vaporizer is a device which converts liquid anesthetics into vapor, which are then delivered to the patients. And flow meter. The flow meter measures the gas flow to the patients during anesthesia. And the next one is ventilator. The ventilator are used now in latest machines. The ventilator attached with the modern anesthesia machines, which are used for mechanical ventilation during prolonged surgery. The safety features in modern medicines include O2 failure alarms, which alarms when O2 supply fails, and also nitrous oxide cutoff, nitrolog, or otherwise called a nitrolog. It prevents the nitrous oxide delivery when there is a reduction in O2 supply. And third one is hypoxic cash mixer alarm. It also sounds if there is any oxygen supply less than 21 to 20% in anesthesia cash mixers. Conclusion, anesthesia machine is a critical device used in modern medicine, which require careful attention to ensure patient safety. With a complex advancements, numerous safety features, anesthesia machine plays a vital role in delivering the anesthesia patients undergoing surgery. Thank you, sir. Thank you, sir.
Thank you, President. Now it is my duty in a thematic address. I have to introduce the faculty today. Today it's a great day because we are eagerly expecting to reach the 4-digit figure, that is 1,000, because the previous webinar was attended by 946 delegates. Today it is on the basic topic, that is Boyle's apparatus, which every postgraduate at the outset they have to know. So here the postgraduate representative, Dr. Shetty, is participating here, and she has done her schooling in Maharashtra. And now she is pursuing her studies in Karnataka. So she has done her MBBS from Dharwad. See, even as a postgraduate, he has completed ACLS and BLS training with the instructor potential. Now I recollect, only after I became the dean, when I was Dean Thiruvarur, I attended the BCLS, ACLS course at All India Institute of Medical Sciences, Delhi. And they have picked only me that I am having an instructor potential. At that time, I was very happy Even though I was out of this academics for 5 years at that time, again, they have located me, but now I'm thinking, oh, this postgraduate under the stewardship of Dr. Madhusudan, she has got the instructor potential even at the postgraduate time itself. Now she is monitoring the instructors. So she is a batch representative in KMC, Mangalore, while doing her MBBS. So probably she would not have picked up any quarrel with the deputy superintendent, Dr. Madhusudan at that time. And see, another one, she has won the, that is second runners-up, silver medal in national tug of war competition by representing Maharashtra. So after seeing only, I know that yes, she is a good candidate for a tug of war. But even then, she is a good Bharatanatyam, trained Bharatanatyam dancer. That is a good thing. Both tug of war as well as the Bharatanatyam dancer. And she has won many prizes in elocution, poetry competitions in the school and college. So best wishes, madam, for a bright future. And it will be followed by Dr.Megha. Immediately, the associate professor is coming up. So she is associate professor of KMC, and she has done her MBBS from Father Muller Medical College, and she has done her MD from SDM Dharwad. So, madam is having a special interest, as usual, as any anesthesiologist. It is regional anesthesiology. Probably, to be more specific, we have to say USG guided regional anesthesia. And she is just looking like a child, innocent face. So, she is interested in pediatric anesthesia. So, both the thing, and again, she is a dancer. So I am see most of the doctors, lady doctors participated in this webinar are dancing. I don't know. They are dancing and their husbands are dancing to their tunes, but they are dancing. Everyone says she's a dancer. Then after the PG, this associate I'm seeing, people when they join MBBS or MD, they are having many laurels, good extracurricular activities. But only after passing out MD anesthesia, they are detached from all the thing, the tug of war, or dancing, everything. Madam is interested in art also. She has won many prizes in the competition at the school and the college levels. Now she is not taking part in any competition because she allowed the juniors to take prizes instead of she herself bagging all the prizes. It will be followed by Dr. Julie Misquith. She is also an associate professor and she has done MBBS, MD, both from KMC Mangalore. I think she is associate professor there itself. It is rare. Everything. She born and brought up in Karnataka. We used to say she was born and brought up in KMC. I don't know. Madam has, in addition, she has undergone short-term pain control course. I don't know why she has entered into the short-term instead of long-term, but just because she has entered into the short-term pain relief, she is catering to post-operative surgical pain and not chronic pain relief. Madam has several publications to her credit. Again, she is also interested in regional anesthesia and pediatric anesthesia. Madam is a fast reader. Madam is a fast reader. Why I am saying sort of voracious reader? She's a fast reader. She is good at running as well as reading. So she will be reading while running. So she is the fastest reader. Again, she is interested in dancing. So her physique says that she is a dancer and a great athlete, but she is a state level athlete. That we have to know. She is a state level athlete. And the very minute point I want to stress, Madam has finished her MD. At the same time, one anesthetist by name Dr. Carl, he has also finished his MD. And to gain practical experience, just like August Bayer inserted spinal needle into his back, they want to try, so they mutually anesthetized each other and they entered into the wedlock. So that is the basic point. And to tackle all these three, we have the moderator, Dr. Madhusudan Upadya, who is my good friend, more than 20 years or 25 years. Even I know his spelling is Madhusudan Upadya. I am the only one who is writing it correctly. The famous quote from him is, Any academic activity or conference is for entertainment as well as for education. And Dr. Madhusudan Upadya is for education and Meenakshi Sundaram is for entertainment, he used to say. So that's what I'm also doing. He's here to educate you. I cannot educate all of you. He's very clear in that statement. And he is interested in obstetric anesthesia and difficult airway. He is not interested in ultrasound guided regional anesthesia. So we are happy in that. And he has 65 publications to his credit, national and international. He's a dedicated teacher. See, he is associate editor of IJA. And he was the editor for Karnataka State Anesthesia Journal. And the basic point I want to stress, he is a member OG committee of WFSA. So, Indian is taking part in the World Federation Society of Anesthesiologists. As he is interested in OG, he has been branded as a OG ambassador by the World Federation. And by step, he has improved. He was a secretary ISA, president ISA, then secretary South Zone. He has organized many conferences. Even one of the conferences he organized in Mangalore, I attended as a faculty. That is an avenue for me to enter into Karnataka faculty group. So in Mangalore, he has done so many PG many academic programs he is doing. We are happy to have him here. And in addition to this anesthesia activities, he is the secretary IMA. And he is a Rotarian, great Rotarian. So in the polio campaign, he has taken active part. So even in the preventive aspect, he was doing that. And even if the polio patients are coming for correction, he used to anesthetize them. And with all these things, he is a good cricketer. He's a good cricketer and he loves music. That music is, if his wife sings, he will listen more. And just now he has returned from Nepal, accompanied his spouse because spouse is a dermatologist, faculty in dermatology conference. So why I elaborate, this sort of a great man attending a weekly webinar is a great credit to the Puthukkotai Society of Anesthesiology. So we bow ourselves to the great team led by Dr. Madhusudan Upadya, who is a keen academician and a great personality. He's a towering personality. See, even in the theatre dress, he is coming for a webinar. That means he is very active in clinical as well as academic schedule. So I hand over the session to Dr. Madhusudan Upadya, and we wish this time we will reach 1,000, our targeted figure, fourth digit figure. So hope for the good news tomorrow. Over to Dr. Madhusudan Upadya. Sir, please take over.
Thank you very much, Dr. Meenakshi Sundaram. I think they were really flowery, great words. I don't think I deserve all this. My CV is fine. It's okay. But the rest of it, I think it was not, it's a little too much. Anyways, thank you, my friend. It's I don't consider your webinars as just weekly webinars because I know how it has been reaching people. We have had webinars which started during the COVID and they have either died down or the numbers started dwindling and they're insignificant basically. Even if the people organizing them are great, the numbers are dwindling because it has fallen out of favor maybe, or maybe it has become too repetitive. People have been finding it difficult to get glued to the monitor during the weekly webinars. But Meenakshi's webinars, even the first episode when he had taken it to maybe about 100, I can't remember the numbers, he had done a great job. It all depends on the topics. If you have student-friendly topics, practical topics, I think people will be attracted to this. In spite of people knowing that these topics are available online later, still, if nearly 1,000 people join, the credit should go to Dr. Meenakshi. Meenakshi is famous. He is a towering personality. We would like to see him as the president of ISA soon. Don't know, maybe next year. Let's see. I think without much of an ado, I invite Dr. Shyvi Shetty. When Dr. Meenakshi asked me to take the basic topics and preferably the machines, Obviously, machines is a huge topic in itself. You cannot be obviously covering everything in a 2-hour webinar. It needed a lot of efforts from me and him to decide about the topics. Since Shyvi is a postgraduate, we thought we will give her about 10 to 15 minutes to talk about one of the basic topics, which obviously the laryngoscopes, still the video laryngoscopes will be main question when you take the viva. Was the table viva, the laryngoscopes will be kept, and you will be asked questions on the laryngoscope. Therefore, we decided to take up only that. Initially, we thought we will take up till the fibroscope, but then the time given is only about 10 to 15 minutes for her. Therefore, we decided to start with laryngoscopes and end with video laryngoscopes. And yeah, the next topic would be Megha's low flow anesthesia. That is a topic which is very dear to me. We'll talk about that once Shyvi finishes. Shyvi, are you ready?
So
Yeah, we will. Yeah.
I'll share the screen, sir.
Yeah, please. And
Yes.
if you have any questions, obviously it will go into the chat box, and we will try to answer the questions at the end of the session, not immediately after Shyvi finishes. Okay. Yeah, Shyvi.
Starting, sir.
Yeah.
Good evening, everybody. My topic for today is laryngoscopes. So what is a laryngoscope? It is basically a device which is used to visualize the larynx and adjacent structures, mainly for inserting a tube into the tracheobronchial tree. So going back to the history of laryngoscopes, the first laryngoscope was invented by Manuel Garcia in 1854, after which in 1895, Alfred Kirsten developed a direct vision laryngoscope, and in early 1940, it was popularized by Sir Robert McIntosh and Sir Ivan McGill in 1940. So, what is laryngoscopy? Basically, it's a procedure in which the larynx is visualized. It is useful for diagnostic, therapeutic, and intubation purposes by various specialists. So, what are the uses of laryngoscope? Basically, it is used for endotracheal intubation, insertion of a nasogastric tube and transesophageal echocardiac probe, foreign body removal, upper airway lesion biopsy, visualizing and assessing upper airway like vocal cords and larynx. So this is basically the view of the larynx we get while using a direct laryngoscopic view. You can see a laryngoscopic blade here. There's an epiglottis. Then we have the vallicula, the arytenoid cartilages, the tongue above, obviously, and the vocal cords through which we pass the endotracheal tube. Coming to the types of laryngoscopes, we have direct rigid laryngoscopes, indirect rigid laryngoscope, which uses basically fiber optic, prisms, and mirrors. Then we have video laryngoscopes, which is a newer method of laryngoscopy. In that also we have rigid and flexible. And then we have the flexible fiber optic endoscopes. Coming to direct rigid laryngoscope, this was the dominant modality since 1940s. The advantage here is it is quick to use, economical, universally available. The disadvantage would be alignment of the visual, oral, and the pharyngeal axis is needed while using a direct rigid laryngoscope. Coming to the parts of a laryngoscope, so we have mainly the handle, the blade, and the hook. Coming to uh, the handle is held in the hand during laryngoscopy. It provides the power for light. It also has a socket to which the blade is attached. The handles also contain the batteries or using fiber optic illumination. And in case they are using fiber optic illumination, then there will be a green band at the top of the handle. It is available in various sizes and it has a rough serrated surface that is basically to have a firm grip. Coming to handles, we have various type of handles. One of the type is the Patil Syracuse handle. As seen in the picture, it can be positioned and locked in four different positions. Namely the 45-degree angle, 90-degree angle, 135-degree, and 180-degree. So here it can be used where the extension of the neck is contraindicated, as in cases of cervical spine injury or cervical spine instability. There are three types of handles. One is the short handle, pencil handle, and the normal handle. If you see in the picture, on the left side, you have a pencil handle which is sleeker. This can be used in the pediatric age group. The middle one is a normal laryngoscopic handle, which we commonly come across. And on the right hand side, we have a short handle. Now, this short handle can be used when the chest or breast tissue is in contact with the hand during the use of laryngoscope, as in the cases of obese patient or in pregnancy where the breast tissue can come in contact. Coming to the next part of the laryngoscope, that is the blade. What are the different parts of the blade? So we have the base of the blade, there's a flange of the blade, there's the heel, there's the tip. These are the major parts. So basically, the base is the one which attaches to the handle. It has a slot for engaging the handle, and the end of the base is nothing but known as the heel. The tongue, as you can see, which is also known as the spatula, it is the main shaft and it is used to compress or manipulate the soft tissue, like mainly the tongue. The flange on the top is basically a guide for instrumentation. And as you can see, the web, that is nothing but the connection between the flange and the tongue, or basically the flange and the tongue is connected via web. Then we have the tip. If you see the tip, it is the one which will be coming in contact with the epiglottis or the vallecula, directly or indirectly lifting up the epiglottis so as to see the vocal cords clearly before inserting the endotracheal tube. Also, we should know that the tip is made in such a way, it is thickened so that it will cause less mucosal injury. So, coming to the types of the blade, we have a Macintosh curved blade, Miller straight blade, and the McCoy flexible tip blade. Now, these are some of the prototype blades, and whatever modification comes further is the modification of these blades. Coming to the Macintosh blade, it is the most popular blade, and the tongue here of the blade has a gentle curve that ends to the tip. In the cross section of the tongue web and the flange, it forms a reverse Z. It is positioned in the vallecula anterior to the epiglottis, lifting it out of the visual pathway. And the various sizes that are seen here would be mainly from size 1 to 4. These are some of the modification of the Macintosh blade. To name a few, the Oxyport Macintosh is basically the one which will have a provision for oxygen insufflation. The Tull Macintosh would be the one which will have a suction port along with the blade, and quite other few. These are all the modification of the curved Macintosh blade. Coming to the Miller straight blade. Now, here the tongue of the blade is straight with a slight upward curve at the tip. The flange, web, and the tongue here, the cross section would form a C with top flattened. As you saw in the previous one, there was a reverse Z formation in the cross section. Now, this is basically positioned posterior to the epiglottis, unlike the Macintosh curved, where it was anterior to the epiglottis. So, here it is posterior to the epiglottis, trapping it while exposing the vocal cords and the glottis. Point to be noted here would be, now Miller straight blade we usually use in the pediatric population because, as we know, the pediatric epiglottis is floppy. So the straight blade here would help us lift the epiglottis and have the view of the larynx better. The sizes ranges here from 0 to 4. These are some of the modifications of the Miller blade, like the Robert Shaw blade, the Oxford infant blade, the Wisconsin blade, the Wishippel blade. One of the blade that we would have heard also commonly would be the Oxford infant blade. Now here the thing is the flange on the proximal end is broader. So what happens is this will prevent the lip from obscuring the laryngeal view. So this is most commonly used in difficult cases like a cleft lip or cleft palate. Coming to the preparation of laryngoscopy. Now, first of all, we have to arrange proper functioning equipment like the suction, oxygen flows, high flows and low flows, airway equipment like the laryngoscope, endotracheal tube, airway, stillet, reservoir, or self-inflating bag. The patient positioning, as we know, the sniffing position, monitor, pulse oximeter, pulse oximetry ECG, esophageal detection device like the capnography and the CO2 detector device, height of the operating table, usually at the level of the laryngoscopist's navel. So this is the technique of laryngoscopy. What is the position? Now, optimal sniffing position would be 25 to 35-degree flexion of the lower cervical spine and 85 to 90-degree head extension at the atlanto-occipital joint. It is using a pillow of 8 to 10 centimeters under the head. No head elevation. As you can see in the picture, we have an infant, a small child, and an older child or an adult. In infant, if we see, the padding is done under the shoulder blades. This is because we want the oral, pharyngeal, and the laryngeal axis to come to align in one line. Hence, the padding under the shoulder blades. If you see the small child, that would be less than 8 years, you don't need head elevation in these kids because their larger head circumferences produce a neck flexion as the head extended at the atlanto-occipital joint. Whereas an older child, more than 8 years, or an adult, we need a proper flexion at the lower cervical spine and 85 to 90-degree extension at the atlanto-occipital joint. So laryngoscope, usually we hold it in the left hand at the junction of the handle and the blade. Optimum mouth opening is done by the scissoring action. Then we introduce the blade into the mouth, usually from the right side, without engaging the lip and the teeth. As half of the blade enters the oral cavity, we sweep the tongue towards the left. Advance the blade along the side of the tongue towards the right tonsillar fossa. When the fossa is visualized, blade tip is moved to the midline. Advancing the blade behind the base of the tongue, elevating it, epiglottis comes into view. From here, two different techniques can be used, which I'll tell you further. So for the curved blade, what we do is, you can see in the picture, it is mentioned epiglottis is below the tip of the blade. So here we advance the blade until the tip fits into the vallecula. Traction is applied along the axis of the handle, moves the base of the tongue and the epiglottis forward, and the glottis comes into view. So here we do not include the epiglottis under our blade, whereas it is in the vallecula and the epiglottis is below the blade. For the straight blade, if you see in the picture, the epiglottis is being lifted directly. So the blade is advanced, epiglottis is identified, the blade tip is passed posterior to the epiglottis, and the blade is lifted anteriorly, lifting the epiglottis. Basically, we're including the epiglottis while doing the scopy, which is most likely done in a pediatric case. Some of the maneuvers to improve the laryngoscopy would be, sometimes the larynx is not visualized even after correct technique. Then what do? We do something known as the burp maneuver, that is backward, upward, rightward pressure on the thyroid cartilage may improve the visualization of the glottis. Also, we can do an optimum external laryngeal manipulation. Coming to the third type, it is a McCoy flexible tip. Basically, here we have a hinged tip that is controlled by a lever attached to the proximal end of the blade. When the lever is pushed towards the handle, the tip of the blade is flexed. Now, tilting or a tilting tip is used for the elevation of the epiglottis. It increases the view of the larynx. Less force is required to intubate. It's a unique design. It causes less risk of trauma, and it is ideal for difficult intubation. In the picture, you can see the top picture shows the lever, and when it is uh, approximating towards the handle, you can see the tip, it is flexing, which will be used to lift up the epiglottis. Coming to video laryngoscopes, it is a new generation method of laryngoscopy and tracheal intubation. In this, the images from the distal end of the laryngoscope blade are carried onto a screen, which is either attached to the handle or carried to by a optical cable. There is superior visualization of the glottic structures. This is basically an aid in tracheal intubation where we anticipate difficult airway. Operator and assistant can see the same view and coordinate better. Also, enhance laryngoscopic teaching to the beginners. So some of the steps that are involved would be, you look into the patient mouth, insert the laryngoscope into the mouth, gently advance towards the root of the tongue. Now start looking at the screen. The position of the laryngoscope is now optimized. Shift back to looking in the mouth. The ET tube with the stellate is inserted gently and placed as close to the tip of the laryngoscope as possible. Then change your side back to the screen, and the ET tube is gradually advanced in between the vocal cords. There are different type of video laryngoscope. The first one that you see is basically a glide scope. Now this one it incorporates a high resolution digital camera which is connected by a video cable to a high resolution LCD monitor, and it is embedded a anti-fogging mechanism. It comes with three models: the standard, pediatric, and the neonatal vision. The second one is a McGrath video laryngoscope, which has a built-in screen. It is similar, the blade is similar to that of the glide scope. Plastic sheath is present for the blade. Here, the depth of the blade is 13 millimeters, easy for patients with limited mouth opening as well. This one is low-cost single-use blade, reduced sterilization time. Coming to the TrueView PCD laryngoscopes, it functions both as optical and video laryngoscope. It can be attached to any other monitor with CCD camera head, provide clear enlarged view, and that would enhance the ease of tracheal intubation. Also, to make a point here would be oxygen flow via side channel on the handle provides continuous oxygenation, so it delays desaturation if any, and it also prevents the fogging of the lens and clear secretion in its path. There are 5 blade sizes from neonates to adults in case of a TrueView PCD laryngoscope. Coming to the Pentax airway scope, if you see here, there is already a blade which has a channel for suction or oxygenation. Also, it has a the ET tube is already channeled in the video laryngoscope here. It provides a good view of the glottis and the adjacent structures. Also, it has a 2.4-inch LCD monitor inbuilt in it. Then we have the CMAC laryngoscope. It is basically the fourth generation video laryngoscope by Carl Storris. It shows a clear image without any fogging. It also has options to record. Available in 4 sizes, size 1 to 4. Then we have the King Vision video laryngoscope. It is a durable, fully portable digital video laryngoscope. It has a high quality reusable display and disposable blades. It comes in 2 versions. One is the channeled version and the other one is a non-channeled. The channeled version will allow ET size of 6 to 8 mm. It also has an anti-fogging coat on the lens and prevents the blurring of view when we do a laryngoscopy. The last one is just to mention over here and not go into depth would be a flexible fiber optic endoscope. Dr. Peter Murphy was the first one to use a flexible fiber scope to perform tracheal intubation in 1967. It has various parts like the light source, handle, eyepiece, focusing ring, working channel ports, tip control lever, insertion cord, universal cord for light transmission. These are the parts that I've already mentioned in a picture form. And some of the essential steps would be ensure appropriate indication, explain the procedure to the patient because most often we would do an awake fiber optic intubation, give pre-medication as appropriate, prepare the equipment, assemble and check the fibroscope, which is very important, prepare the local anesthetic solutions, monitoring oxygen and intravenous access, commence the sedation if being used, position the patient and ensure appropriate level of sedation, anesthetize the airway. Airway preparation is very important when it comes to fiber optic intubations, and confirm the correct ETT positioning. Cleaning of the rigid laryngoscope, it would be you have to remove the batteries and clean the handle with water and detergent, then with alcohol. Usually handles can be sterilized by using steam, plasma, or ETO. Disposable covers are also present for these handles and blades. For flexible endoscope, it is best to decontaminate in an endoscopic unit, and there are several steps that would be followed to clean the same. My references. Thank you.
That was superbly done, Shyvi. Thank you so much. As I said, the questions will be taken at the end of the sessions, but to tell you, the video laryngoscopes basically have revolutionized the way you look at the airways. And once the fiber optic bronchoscopes came into the market, obviously there's nothing which, no airway which cannot be conquered by an anesthesiologist. Anything can be handled by an anesthesiologist. But I still remember one of the most famous anesthesiologists, Dr. Ramesh, saying, once the VLS came, the conventional laryngoscopy has taken a backseat, and the trainees find it very difficult to handle the direct laryngoscopes. I think that kind of a situation should never come to us, because direct laryngoscopy on any given day, I think, is the issue which will save our life, our patient's life too. VLS can be an add-on, but obviously direct laryngoscopy is the procedure to conduct. And it will be available in any setup you go to. And VLS, obviously, there are a lot of video laryngoscopes available to you in the market. It all depends on which one you need. It depends on your budget and your requirement. Disposable blades, they themselves are expensive. Therefore, you have to consider which one to use. But be safe and know everything as a postgraduate, including the fibroscopy. Now, we will move on to the next topic. As I said, the Megha's topic, the low flow anesthesia, is actually my love. Ever since I heard Professor Ravi Shankar talking about low flow anesthesia, and he had written an article on low flow anesthesia in one of the CME notes, I think it was Race, long ago, I fell for it. And then I started practicing. I think there is no more joy than practicing low flow anesthesia in anesthesia. I think that everybody should be able to practice low flow anesthesia. Even if I convert 10% of people watching this session to change to low flow, ultra low flow anesthesia, I think the purpose is served. Over to Megha for a lecture on low flow anesthesia.
Am I audible, sir?
Oh yeah, yes.
Okay.
And slides are seen too.
Okay. So, good evening, everyone. I'll be talking about low flow anesthesia. I am Dr. Megha T from KMC Mangalore. So, I'll be discussing under the following headings the definition. What does low flow anesthesia mean? What is the need for low flow anesthesia? And from theory to practice, that is, how do we practice low flow anesthesia? So what does low flow anesthesia mean? So as the term says, it's low flow, but how low should be the flow? So the fresh gas flow, which is significantly lower than the minute volume, this is nothing but low flow anesthesia. I'll talk about it in detail. Usually, it is carried when such low flows are used. The anesthetic gases must be conducted to the patient via a semi-closed or even a closed rebreathing system. As you know, when a higher fresh gas flow is used, most of it gets vented out. The excess gas gets vented out. However, when a low fresh gas flow is used, the carbon dioxide from the exhaled gases will be absorbed by the by the absorber, and this gas will add on to the fresh gas flow and will be delivered to the patient. Hence, the rebreathing fraction increases in this case, whereas the volume of excess gas decreases. So, coming to the history, as early as in 1850, John Snow recognized that a considerable amount of inhaled anesthetics were exhaled unchanged in the expired air of the anesthetized patients. And he mentioned about this in 1850 in the London Medical Gazette. He concluded and could prove that the narcotic effect could be markedly prolonged by re-inhaling these unused vapors. So when we say narcotic effect, we should not be confused with respect to opioids. He meant with respect to anesthesia, it could be prolonged. Hence, we can see that the technique of reusing the expired gas for alveolar ventilation after absorption of CO2 can be traced to as early as 1850s. Later on, Dr. John Snow, he used the caustic potash to absorb the carbon dioxide from the expired gas. This concept was further simplified by the introduction of true and fro system by Waters and circle system by Brainsford, who used soda lime for the absorption of carbon dioxide. So you can see the picture of to and fro system by Waters, and this is the picture of circle system, which we even use now, which was done by Brainsford. In the early half of the century, it reigned supreme. I mean, the low flow anesthesia reigned supreme when expensive and explosive agents like cyclopropane were used. This is because cyclopropane was very expensive and they couldn't afford to lose with high gas flows, and hence low flow was used. But however, with the introduction of halothane, and even before the introduction of halothane, Folds et al. In 1952, he described low flow anesthesia, that is with 1 liter per minute of gas flow. But in 1954, halothane was introduced. So by the introduction of halothane and plenum vaporizers, which worked well with high flows, again the low flow anesthesia became less popular. And other reasons because of which it became less popular was they added knowledge of disadvantages of using high percentage of oxygen for prolonged period, necessity to use a second gas to control the percentage of oxygen, and because of the complexities involved in the calculation of uptake of anesthetic agents during the closed circuit, it became less popular. But in later on, again, because of the awareness of the dangers of theater pollution with trace amounts of anesthetic agents, and also because of high cost of the new inhalation agents, the rediscovery of low flow anesthesia occurred. So this was the history. So coming to the definition, as I said earlier, any technique that uses a fresh gas flow that is lesser than the alveolar ventilation can be classified as low flow anesthesia. Baum et al. In his article mentioned that it is a technique where at least 50% of the expired gases had returned to the lung of the patient after the carbon dioxide absorption. Baker further classified based on the flows into metabolic flow, which is about 250 ml per minute, minimal flow, which is 250 to 500 ml per minute, low flow, 500 to 1 liter per minute, medium flow, which is 1 to 2 liter per minute, high flow was 2 to 4, and very high flow is 4 liters per minute and above. So we can see here that the low flow is 500 to 1000 ml per minute. So when fresh gas flow is more than minute ventilation, this delivers a constant composition and most of the expired gas is vented out. So the composition doesn't vary much depending on the time of anesthesia. But as the fresh gas flow decreases, the chance of delivery of hypoxic mixture increases. The reason is rebreathing. As I said earlier, after the removal of carbon dioxide, it gets added on to the fresh gas flow. So there will be further dilution, which can result in delivery of hypoxic mixture. Hence, this is the reason for fear in most of them to practice low flow anesthesia. So in this graph, you can see this is the fresh gas flow liters per minute, whereas this is a percentage. So the higher the flow, lesser is the percentage of rebreathing. As you decrease the flows, you can see the percentage of rebreathing goes up. So exactly about 2, when you see here, when you 2 liters per minute, when you go below that, almost 50% of the rebreathing occurs. So what I said earlier, you can see with high flow, there's only 0%. And as it goes above, the rebreathing percentage increases. When it comes to low flow, you can see that 86% of rebreathing occurs. Before going into the details of low flow anesthesia, there are few things which we should know. One among them is the uptake of oxygen, nitrous oxide, and volatile anesthetics. As we know, oxygen is continuously taken up from the system by a patient at a rate which corresponds to his basal metabolic rate. It takes place at a rate which can be calculated using a simple Brody's formula. So uptake of oxygen 10 into the weight of the patient to the power of 3 by 4. A simplified Brody's formula is uptake of oxygen is equal to 3.4 into body weight. So roughly, if you take a patient, 60 kg patient, around 240 ml, so approximately 250 ml per minute of oxygen is taken up. And this remains approximately constant throughout in stable conditions unless patient is hypermetabolic or patient has a low cardiac output status, then it can come down. Otherwise, approximately 250 ml per minute is taken up by the patient. And for nitrous oxide consumption, Severingus formula is used. You can see that the uptake of nitrous oxide is equal to 1000 into 10 to the T, that is time, into the power of minus half. That is nothing but square root of T. So as you can see, the uptake is inversely proportional to the time. This means as the time goes on, the uptake of nitrous oxide comes down. That is, with increasing duration of anesthesia, tissue compartments become saturated and the uptake slows. So, so the uptake is mainly determined by the alveolar arterial partial difference. As I said, it's high at the beginning, but in the course of time, it becomes less. So for anesthetic agent uptake, there's another formula. This is mainly subject to the composition of the gas in the anesthetic system remaining constant, and the uptake of inhalation agents like nitrous oxide decreases over the course of time. So the formula used for uptake of inhalation anesthetic is Loeys formula. That is uptake of anesthetic agent. F is nothing but the desired expiratory anesthetic concentration as a function of MAC. That is, if you are wanting 0.8 MAC, then 0F will be 0.8 MAC. This is blood gas coefficient. Q is cardiac output and T is the time. So here also you can notice that the time is inversely proportional to the uptake of anesthetic agent. That is square root of time half minus half to the power half is nothing but square root of time. So the uptake of volatile anesthetic is inversely proportional to the time. So like nitrous oxide, with the time, the uptake decreases. Initially, it will be high, but later on decreases. So pictorially, these formulas are depicted in this graph. So this is graph, as you can see, it's the total uptake ml per minute, and here is the time. The white one is oxygen. So as I said, 250 ml per minute approximately is taken up by a patient. So throughout time, it will remain the constant, that is 250 ml per minute. Whereas the pink color is the isoflurane. As you can see, the initial uptake is high, but later on it decreases and stabilizes. Likewise, the blue one is nitrous oxide. The initial uptake is high, but later on it decreases and stabilizes. Okay. So you can see that around 10 minutes onwards, all this comes down, the uptake of volatile anesthetic as well as nitrous oxide. Now, this is a graph of uptake of volatile agents, that is individual volatile agents. So common thing what you have to notice is initial consumption is high, and as the time passes, it falls down dramatically. So the clinical implication here is initial phase, we require high concentration, but later on, the uptake decreases, so lesser concentration is required. So all these different flows, that is the red line is low flow anesthesia, whereas the dotted line is the minimal flow. On what I showed earlier, on these, the different flows are superimposed. So you can see in low flow anesthesia, we start at 4 liter and later on come down to 1 liter per minute. Whereas in minimal flow, you start at 4 liter and later on you come to less than 500 ml per minute. So imagine if there is another line which is high gas fresh gas flow, that is more than 4 liter. So it will be going this way. So the difference between what we are delivering and what is actually uptaken by the patient is there's a big difference. So you have to note that. So what is our aim in low flow anesthesia is to achieve an alveolar concentration of the anesthetic agent that is adequate for producing surgical anesthesia. So various group of drugs are combined. We use opioids, we use IV induction agent. Hence a MAC of 0.8 to 1.2 is needed for anesthetic depth. There are, as we all know, the factors influencing the buildup of alveolar ventilation, inhaled concentration, that is circuit volume. More the circuit volume, more time it takes. Set inspired concentration, then rise in alveolar tension. So alveolar ventilation and concentration effect. Concentration effect is with respect to nitrous oxide. That is more the nitrous oxide, more will be the uptake of the volatile anesthetic. And uptake from the blood, blood gas coefficient. That is higher the blood gas coefficient, lesser will be the uptake. Cardiac output and alveolar venous gradient. This is just to give an idea about the uptake and distribution of inhaled anesthetic. So fresh gas flow, this is the vaporizers to the circuit, goes to the alveoli. Pulmonary blood flow takes up the inhaled anesthetic. So vessel-rich group, then it goes to the muscle and later on to the fat. So vessel-rich group includes brain, heart, liver, and kidneys. So this is regarding the uptake. So what happens to the expired gases? I have told this, carbon dioxide is absorbed by the soda lime, whereas oxygen, nitrous, volatile anesthetics is not absorbed and it will mix with the fresh gas flow. Hence, a resultant dilution of gases occur, oxygen and volatile anesthetic. So hence, if I set a FiO2 of 60%, the exhaled gas will have less FiO2 and then it will go and mix with the fresh gas flow, which has 60%. So lesser FiO2 exhaled gases, 60% FiO2 fresh gas flow. This will mix up, hence the resultant FiO2 will be less. So what we have set on the dial or what we have set on the flow meter might not be actually be delivering to the patient. So this we have to keep in mind. So there's something called as time constant. Before going to the time constant, we'll just talk about the reserve volume. It has two components. One is related to the apparatus and one is to the patient. So related to the apparatus, it's usually volume of the circuit, which is around 1.5 liters, reservoir bag or ventilator, 2 liters, and canister 2 liters. So the volume of the apparatus is around 6 liters. Adding on to this, the other component, that is the patient, we usually take FRC into consideration. So that is 2 liters. So 6 liters per 2 liters, making it 8 liters. So why is this important? Because the anesthetic gases and vapors have to be fed into this large reserve volume. That's why it's important. And time constant, this is very important when we talk about low flow anesthesia. So we can see time, this is a formula by, it's called as Conway's formula. Time constant is not by effective volume divided by flow rate. So effective volume is nothing but the reserve volume, which I spoke earlier about. So it is the measure of the time taken for the alteration in fresh gas flow composition to lead to corresponding changes of gas composition within the breathing system. So that means if I change the CO concentration from 3 to 5%, how long will it take to affect the patient? That is what time constant means. So as we know, time constant is effective volume by flow rate. So one time constant will cause a 63% change, whereas 2 causes 86.5 and 3 time constants will cause 95% change in the composition. To explain it further, this is just a pictorial depiction that the first compartment of the time constant will be from vaporizer to circuit and then circuit to alveoli. This again, what I said earlier, one time constant will be 63, 2 time constant will be 86%, and 3 time constant will be 95%. So to understand better, there's a comparison. As I already said, that this is the Conway's formula. That is, time constant is effective volume divided by flow rate. So imagine effective volume 6 to 8 liters, I told, but for easier mathematical calculation, we'll take it as 6 liters. So in a patient where we are using high fresh gas flow, effective volume 6 liters divided by flow rate, I have kept at 6 liters. So 6 by 6, the time constant is 1 minute. So we are more worried about the 3 time constants, that is 95% of change in composition occurs by then. So 1 into 3 will be 3 minutes. So it means that it takes 3 minutes for a change at the patient end. That means if I change the dial setting at my end, at least 3 minutes it will take to reflect on the patient end. However, just see if it's a low fresh gas flow, the effective volume I said 6 liters, and flow rate, like low flow anesthesia, we have kept at 1 liter. So T will be 6 minutes. So 3 time constants will be 6 into 3. That will be 18 minutes. So it takes 18 minutes for change at the patient end. So you have to note this. In high fresh gas flow, the change is immediate, but in low fresh gas flow, the time taken, there's more time taken. So in case a patient has a hypertensive response and you want to increase, you can give other things, opioids and all, but if you want to increase the setting, it's based on the time constants. At least 3 time constant it will take to reflect at the patient end. So as I said, if the fresh gas flow is high, the changes are reflected immediately, but that does not happen when the fresh gas flow is low. So what I change to reflect on the patient end, it will take that much time. So when the time constant is longer, the dilution also occurs further, causing delay in induction. Hence, whatever we have set at the patient end might not be the same that is delivered. So coming to the equipments that we require for low flow anesthesia, carbon dioxide absorbers, monitors, and circle system. So monitoring equipment, I'll tell you in detail. Anesthesia apparatus, low flow rotameter. It is said that rotameter which goes as low as 50 ml per minute should be there. But as we know, in some of the machines, there is a safety mechanism, that is a minimum obligatory flow of 200 ml is maintained even when you come down in order to avoid hypoxia. So this can be an hindrance, especially in low flow anesthesia. And vaporizers which can even deliver higher concentration should be available. And the leakage, less than 100 ml at 20 centimeter of water should be the less leakage. Because already we are using low flows, and leakage further can cause gas volume deficiency. And side stream analyzers which were used, especially it takes up around 50 to 200 ml per minute of gas goes to the side stream analyzers. So if you're already delivering 500 ml and 200 ml goes out, then it will cause gas volume deficiency. Hence, even if the analyzer takes up, it should be like that. It should be returned back into the circuit. So that would be better. So monitoring equipment, what are the monitoring equipments that we require? As we know, saturation of end tidal carbon dioxide, inspired concentration of oxygen, tidal volume, reservoir ventilator bellows, pyrometer, and volatile anesthetic and nitrous oxide analyzers, that is both inspired and end tidal concentration. That is mainly a gas analyzer is mandatory to measure the inspired and expired concentration of the gases that we are using, like oxygen, nitrous oxide, and volatile anesthetic. So coming to we have seen the theory part. Now, how do we practice? So it has been divided into 3 phases: initiation, maintenance, and termination. So initial high flows, as we have seen in the initial graphs, the initial uptake is very high. Hence, to achieve an alveolar concentration of anesthetic agent, it's important to have an initial high flow. So our aim here is to achieve an alveolar concentration of anesthetic agent that is adequate to produce surgical anesthesia. As well, the anesthetic concentration you can say as 0.8 to 1 MAC that is required, end tidal anesthetic concentration. During this initial phase, the adequate denitrogenation and redistribution of anesthetic gases in the desired concentration throughout the system is achieved, as well as the desired level of anesthesia is attained. So initial high flows also helps with sufficient denitrogenation, reducing time constant, and establishing the required concentration of volatile agents. So there are 4 methods that have been described to achieve the desired gas and agent concentration in the initial phase. So it's like one of the 4 you are using. You either high flows for a short time, a pre-filled circuit, or use of large doses of anesthetic agent. That's also called pressurization, and injection of volatile anesthetics. But what we commonly use is high flow for short time. This is the most effective and the commonest way of initiating the low flow anesthesia. So what happens is high flows are given for a short time. As we have seen earlier, time constant is reduced and the circuit concentration of the desired to the desired concentration is achieved rapidly. So as you can see in this picture, there is a high flow which is kept. Later on, once a patient is pre-oxygenated intubated, then we switch on to the low flows. This black line is nitrogen, that is they are showing the this one is nitrogen, they are showing the denitrogenation that has occurred. With pre-oxygenation, the oxygen levels have increased, and later after intubation you come down on the flow, that is oxygen they have decreased to 1.4 and nitrous oxide to 3. So as we know that initial uptake in the initial 10 minutes are higher, the low flow are started only after 10 minutes. Earlier, a fresh gas flow of 10 liter of the desired concentration with a 2 MAC agent was used, so that by end of 3 minutes, the circuit would be ready, to be brought to the desired concentration. But at present, often a flow of 4 to 6 liters per minute is used for 10 minutes. So how to go about the initiation? You pre-medicate, pre-oxygenate, induce the patient as usual. Then you go ahead with intubation. After intubation, the fresh gas flow of 4 liters per minute for around 10 minutes with the 40% concentration of oxygen and 60% nitrous oxide is used. So the vaporizer setting usually will be 1 to 1.5% of DES. When you're using CO, it should be 2 to 2.5. And ISO was 1 to 1.5, 2 to 2.5 of CO, and 4 to 6% of DES. So what you want to achieve is an end anesthetic concentration of 0.8 MAC. After 10 minutes, the MAC of 0.8 would have been achieved. But here, since we are using nitrous oxide and oxygen, you can note that the 0.0 MAC of anesthetic agent plus 0.6 MAC of nitrous oxide is getting added up. So approximately 1.2 MAC is achieved. That is AD95. AD95 is nothing but anesthetic agent concentration, which 95% of the patient tolerate as incision without noticeable reaction. So what I mentioned earlier is shown in this column. So initial phase lasting up to 10 minutes, that 20 minutes is with respect to minimal flow. A high gas first flow is used 4 liters, 1.4 liters of oxygen and 3 liters of nitrous. So 1.4 here almost approximate to 32% of oxygen. So the setting of halothane, ISO and CO are mentioned here. So once at the end of 10 minutes, end concentration of volatile corresponding 0.8 MAC would have been achieved. Since we are using 60% of nitrous, total MAC of 1.3 will be achieved. Hence, a large flow and high concentration in the initial stage compensates for the large uptake that is seen at the start of anesthesia. So what are the advantages? Rapid achievement of the desired concentration, ability to prevent unexpected raise in the agent concentration, better denitrogenation, and ability to use the commonly available plenum vaporizers to achieve the desired concentration. But however, because of the high flows, we would compromise on the economy, as well as there can be theater pollution, for which scavenging system has to be used. So these were one of the commonest method used, but there are other 3 methods which I'll just mention. Pre-filled circuit is nothing but for pre-oxygenation, you are using a different circuit like a McGill's or Baines. Simultaneously, circle system is fitted with a test lung and entire circuit is filled with a gas mixture of desired concentration. So pre-oxygen is here, they're using McGill's, and simultaneously the circle system, you can see their desired concentration is achieved by filling it. And once patient is intubated, they connect the circuit. Injection technique is by directly injecting the agent into the circuit. This is an old time-tested method. The volume of liquid injected at each time interval during anesthesia, there are formulas and normograms for that. Even infusions have been used. Here, just for an idea, 1 ml of halothane gives around, roughly, both halo and iso gives around 200 ml of vapor, 1 ml of the agent. Hence, a 2 ml agent is required in the first 10 minutes. That is around 400 ml that is required. So at a time, you should not exceed 1 ml. 0.2 to 0.4 ml aliquots are given. This is a formula which is used to calculate the exact dose. The last method would be to use a larger dose of anesthetic agent. Here, a large amount of anesthetic agent is used. In the initial 10 minutes, the flow is kept low, but the percentage of the fresh volatile anesthetic is high. So after 10 minutes, you are supposed to come down on the decrease the concentration of volatile anesthetic. So, but we'll usually what we do is a larger flow for shorter time. That is what we do. As I saw earlier, expiratory concentration of the volatile anesthetic resulted in a MAC of 0.8. But because we are using nitrous, it resulted in around approximately 1.3 MAC, which is AD95. But when we don't use a nitrous oxide, the anesthetic concentration of 1 to 1 point MAC together is required, and a supplemental dose of opiates has to be given just to compensate for the missing effect of the nitrous oxide. So the loss of analgesic effect can be compensated by opioids, and the reduction in the hypnotic effect can be compensated by increasing the concentration of inhalation agent by 0.2 to 0.25 of the MAC value. So, so this is in absence of nitrous oxide. So what I earlier told about gas volume deficiency, that is, as we know, high fresh gas uptake in alveoli occurs in 10 minutes, up to 10 minutes in low flow, whereas up to 20 minutes in mini flow. So it is seen that if nitrous oxide oxygen mixture is used, an adult patient of average weight after 10 minutes still takes about 600 ml of gases per minute of gas. So at that time, if the fresh gas flow can be reduced to 1 liter, there is no problem, because we are reduced to 1 and patient is taking up 600. However, if you further reduce it to 0.0 liters per minute already, like in a minimal flow, then more gas would be extracted, because you are kept at 0.5 liters, that is 500 ml per minute, but patient is taking 600 ml per minute, and hence more gas would be extracted, causing gas volume deficiency. Hence, fresh gas flow is reduced before stabilization of the uptake that has occurred in the initial period. So what can this result into? It can cause decreased tidal volume, change in ventilatory pattern, and inadequate depth of anesthesia. So that has to be kept in mind. Same thing what I said, you can see that this is the 90 kg patient, whereas the dotted one is a 50 kg patient. The red line is 1 liter per minute, and 0.5 liters per minute, and this one is the dotted blue line is 1 liter per minute. So after 10 minutes, when it's decreased to 1 liter per minute, there's no problem. But immediately after 10 minutes, if it's decreased to 0.5 liters per minute, then the volume of fresh gas flow falls below the total gas uptake, that is causing gas volume deficiency. Coming to the maintenance part, this is the most important phase. This is stretched over a period of time, and financial savings results directly from this. And this is a need for steady state anesthesia, that is, the patient is maintained throughout the surgery in this state. Minimal uptake of anesthetic agents occur, as I told earlier, and our aim is to prevent a hypoxic gas mixture. So maintenance phase, the oxygen consumption remains constant, but nitrous and volatile anesthetic consumption falls drastically, as seen with the previous 3 formulas. So adding small amount of anesthetic gases to match the uptake, as well as providing oxygen for the basal metabolism, should suffice. If flow is used, then besides the uptake, the amount of gas which is vented out is added to the circuit to maintain a steady state, hence causing dilution of oxygen and volatile anesthetic. So hence a slight increase in the concentration of oxygen and volatile anesthetic should be done because of uptake and dilution. So the exhaled gas is added to the fresh gas flow, and it's delivered to the patient, causing the dilution. Hence, it is at least minimum 50% of low flow, the oxygen has to be maintained to avoid any hypoxia because of the dilution effect. And your LRAM usually, actually the aim is to set an inspiratory concentration above 30%. But however, it is noted that an inspiratory oxygen concentration of 30% can only be maintained if the fresh gas oxygen concentration is increased to 50% once the flow has been reduced. So when the gas flow is reduced to 1 liter per minute, increased inspired concentration to 50% in order to avoid hypoxia. As well as to the scene, the vaporizing sector, we saw that earlier in the initiation phase, we had kept 1 to 1.5% of ISO and 2 to 2.5% of CO. Whereas in maintenance phase, you have to increase it a bit higher because of the dilution effect. Hence, our aim is to maintain the end expiratory concentration of volatile anesthetic as 0.8. So just a mention about oxygen and nitrous. So as you know, oxygen uptake 4 ml per kg per minute, that is comes to 250 ml, so which is constant. Hence, there is a constant removal of oxygen at the rate of 200 to 250 ml per minute, whereas the insoluble gas of like nitrous oxide uptake would be minimal. Hence, the gas that is partly vented out and partly returning the circuit will have more nitrous oxide and less of oxygen. Over a period of time, due to mixing of fresh gas, that is 66% of nitrous oxide and the expired concentration, carbon dioxide with much higher nitrous oxide, the percentage of nitrous oxide will go up and that of the oxygen will fall. Sometimes this can cause dangerous hypoxic mixture being delivered to the patient. So the maintenance phase, the inspiratory oxygen concentration changes continuously during the course and extent of low flow anesthesia. And you should know about the individual oxygen consumption and nitrous oxide uptake that takes. So this is a graph. You can see that the inspiratory oxygen concentration during the course of low flow anesthesia. So the red line depicts the composition of fresh gas flow, that is almost 50-50, that is 0.52 liters per minute of oxygen and 0.5 liters of nitrous oxide. Whereas the dotted line shows a composition of 0.4 liters per minute of oxygen and 0.6 liters per minute of nitrous oxide. So with the time, you can see when you're using 0.4 and 0.6, it can come down the minimum FiO2 we want, that is below 30%. If that happens, then you have to increase the oxygen by 10% and come down on nitrous oxide by 10%. Okay, there's one more graph. Similarly, here the patient is 80 kg, whereas the red line depicts a patient with 50 kg. So you can see that when a 0.32 liters per minute of oxygen and 0.2 liters per minute of nitrous oxide is used, it is way above our cutoff limit of FiO2, that 30%. But with the time, especially in a patient who is 80 kg, that is a well-built patient, with time this can come down below the minimum limit of FiO2 that we need. So this has to be watched for. So what I said, in maintenance phase, the FiO2 has to be maintained at least 40 to 50%. Monitoring is important. In case it falls below 30%, what we have to do is oxygen has to be increased by 10% and nitrous oxide decreased by 10%. That is in low flow, increase oxygen by 100 ml per minute, whereas nitrous oxide will be to decrease by 100 ml per minute. One more thing is surgery is going on, you're in the maintenance phase. You need to change the depth of anesthesia. I like an example, a surgeon is asking for hypertension or there's a pain response. As you know, the time, because of the time constant, the change, it will be with low flows, it takes a lot of time. Hence, during that time, for immediate change, what you can do is increase the fresh gas flow to 4 liter, increase the dial setting to 0.5 to 1% above or below the desired level as required. And once the desired concentration is reached, you can come down on the fresh gas flow. So termination of low flow anesthesia, there are 3 things that are mentioned: coasting, high fresh gas flow, and activated charcoal. Coasting is nothing but turning off the vaporizer 15 minutes. That's with the low flow anesthesia itself. So you can keep the flow, but you cut off the vaporizer 15 minutes prior, like when they start suturing or something. And washing out the anesthetic gases with 5 liters of oxygen just 5 minutes prior to extubation. So this has the obvious advantage of simplicity, but would result in wastage of gases. So already mentioned, so recovery phase, this is coasting, 15 to 20 minutes prior, you cut off the vaporizer, but just 5 minutes before extubation, you switch off to high flow of pure oxygen. And this is just activated charcoal. Towards the end of anesthesia, gas is directed to an activated charcoal canister, which results in rapid recovery, at the same time reducing theater pollution. So just summarize what I've already told. gas flow in the initiation phase, 4 liters of oxygen. Here we are using oxygen and nitrous oxide mixture, that is 1.4 liters per minute of oxygen and 3 liters of nitrous. And these are the settings of the volatile anesthetics. By 10 minutes, end expiratory volatile anesthetic concentration should have been corresponding to 0.8 MAC. So after 10 minutes, once the desired MAC is achieved, the flows are reduced to 1 liter per minute, but throughout should remember to maintain a FiO2 of 50%. And because of dilution, the ISO and CO has compared to the initiation phase, the concentration has been increased. And towards the end, coasting, that is cutting off 15 minutes prior, whereas 5 minutes prior to extubation, increasing the oxygen levels. So coming to the end of the topic, what are the advantages and what are the disadvantages? So as we know, economy, reduced OR pollution, reduced environmental pollution, heat and humidity. So economy, using 6 liters per minute of gases for 2 hours, you use around 720 liters, whereas 500 ml you use for 2 hours, you are using only 60 liters. And as we know, a bottle of the inhalation anesthetic is very costly. So that is why low flow anesthesia, one advantage is economy. Whereas reduced OR pollution and reduced environmental pollution, as we know, isofluorine and halothane are halogenated chlorofluorocarbons, causes ozone depletion. Whereas our CO and DESFL are fluorinated, halogenated fluorides, we can cause greenhouse effect. Hence, OT as well as environment pollution is reduced. Humidification and warming, that is because of the exhale, after the absorption of CO2, heat and water are released, which add-ons to the fresh gas flow, and hence heat and humidity is conserved. This is important because it maintains and preserves the mucociliary clearance by having an effect on the epithelium, respiratory epithelium. So disadvantages, as we know, more attention is required. Anesthetist has to be aware, alert, watch for hypoxic mixture, keep an eye on the flow meter, on the dial concentration, so that he does not deliver a hypoxic mixture, nor he delivers less amount of volatile anesthetic, causing awareness. Other things are inability to quickly alter because of the time constant, may not be able to quickly alter only with low flows. Dangers of hypercapnia, because they are flowing through the soda line. If soda line get exhausted early, you should keep a watch on that. They can lead to hypercapnia. And accumulation of undesired gases. There are few things, trace gases that can get accumulated: carbon monoxide, acetone, compound A, argon, and nitrogen. Problem with carbon monoxide is usually when a desiccated soda lime is used, carbon monoxide is said to accumulate. And also when bara lime is used, which has barium hydroxide, which is not used in India, it can cause carbon dioxide accumulation. Acetone and methane, they are accumulating any very less quantity, so nothing to worry about. But it's said that if a patient is intoxicated with alcohol, or a patient is having diabetic ketoacidosis, then acetone can accumulate. Hence, a fresh gas flow at least of 1 liter per minute to wash out this is needed. Compound A, as we know, sevoflurane is associated with compound A. Compound A is supposed to cause renal tubular acidosis, but 1 liter per minute has been approved, said by FDA, that it can be used over 2 MAC hours. But for compound A itself to cause renal tubular acidosis, at least 880 ppm per hour has to be produced. But with 1 liters per minute for 1 MAC, the compound A produced is only 20 ppm. Hence, even if you use for 10 hours, the compound A that is accumulated is not much. And uncertainty about inspired concentration. Hence, you should be alert because of dilution, what we set might not be delivered, and faster absorbent exhaustion. Other disadvantages are short duration surgery. It might not be applicable, especially if a patient is undergoing a DNC, which is only 15 minutes procedure or so, and 10 minutes you take for initiation itself, hence it might not be applicable. And capital investment, a gas monitoring equipment itself costs around 4 lakhs. So every institution or an hospital might not be able to afford, hence that can be a problem. So to conclude, low flow anesthesia today is safe and simple, that there are no reason not to use it. The use of unnecessary fresh gas flow can be avoided. We can reduce the anesthesia gas consumption up to 75%, and also the greenhouse effect that is caused by the emission and its impact on the ozone layer. So all the economical, ecological, and clinical advantages therefore favor in return towards the rebreathing technique. Thank you.
Yeah, it was quite exhaustive, and you have covered almost all of the practical aspects of how to initiate, and I think it is overall a very good lecture. Again, the questions we'll take it at the end. As Dr. Megha emphasized, short duration surgeries, it may not be very useful for us to resort to low flow anesthesia, but for the thrill of it, I think it is still worth it. As I said, being watching most of the times itself is very exciting, how it changes. But then we'll take the questions later. Nitrous oxide is one agent which I haven't used over the last 10 years. Therefore, it's still exciting to use low flow anesthesia without nitrous oxide too. And nitrous oxide actually adds to the problems associated with the accumulation and maybe the hypoxic mixtures being delivered. Watchfulness is the bottom line, and the economy of the gases and the greenhouse effect of all the anesthetic gases, I think we all should move towards the low flow anesthesia. Thank you very much, Megha. We'll take the questions at the end. Yeah, now one of the most commonly asked questions in the table YOOC and in the theory of anesthesia is safety features of anesthesia machine. There is a lot to talk about the safety features, but in the allotted half hour, Dr. Julie, an associate professor with us in KMC Mangalore, will try to cover the topic. Over to Julie.
Thank you, sir. I'll be sharing screen now.
Yeah, sure. Yeah.
Can we see now, sir?
Yeah, sure.
Yeah. Thank you. At the outset, I'd like to thank Clarinet and the ISA Puthukkotai branch for giving us this opportunity to be part of this weekly webinar. I welcome everyone and I thank you all for joining us. And today I will be discussing the safety features in anesthesia machine, which is vital to ensure both patient and operator safety. So the objectives of this talk will be to understand the importance of safety in anesthesia delivery. I'll go through an overview of the key safety mechanisms, and we'll try and understand the critical safety features in the anesthesia machine. Now let's take a brief thing into the evolution of anesthesia machines. Just a second. Anesthesia machines, from early challenges to the adoption of safety standards given to us by the ISO and ASA guidelines. Now, the first anesthetic machines appeared following their public demonstration by Morton in 1846, what is now known as the ether dome. These initial devices were simple inhalers based on evaporation of anesthetic agents like ether, chloroform. But at the beginning of the 20th century, gas machines emerged, allowing application of anesthetic flow, and we commonly know this as the Boyle's apparatus. Even when I was a postgraduate, we used this machine. And the subsequent developments in the machine were dictated by convenience, functionality, the advancements in technology, and the need for safety, leading from Boyle's machine being replaced by the anesthesia delivery unit, which we now call modern anesthesia workstations. These machines deliver gases and inhalational agents. They have the facility for patient monitoring as well as incorporating advanced ventilation modes. But more effective is the patient monitoring and the safety features that these machines have now. Now, various national associations of anesthesiologists have recommended minimum safety features for anesthesia machines, but anesthesia machines more so are covered by the American Society for Testing and Materials, the ASTM, which follow the guidelines laid by the American Society of Anesthesiologists, the Canadian Society of Anesthesiologists, and the New Zealand College of Anesthetists. So more of our safety features are based on the guidelines provided by them. Now, in most new machines, pneumatic systems can be divided into high pressure system, the intermediate, and the low pressure system. So safety features are incorporated into every single component of this machine, of these systems. Now, coming to the high pressure system, it consists of cylinders, their yoke assemblies, cylinder pressure indicators, and pressure regulators. Now, coming to cylinder safety considerations, first, it's just the on the cylinder itself, there's proper storage and handling. It always has to be stored upright and secured to prevent accidental tipping. Regular inspections have to be done by hydraulic testing, steel cylinders every 10 years and composite cylinders every 5 years. Slow valve opening, 3 to 4 turns to prevent rapid, it should be slowly done because it should prevent rapid decompression and potential explosions. Now, between the cylinder valve outlet and the yoke, there's the Bodoc seal. And in every cylinder, the date when the next test is due appears on the plastic disc attached to the neck. And all these components are given in each cylinder, which has to be tested. Now, the next safety feature I'll be talking about is the pin index safety system. Now, the hanger yoke of the machines which support the cylinder have the pin index safety system, which prevents the attachment of the wrong cylinder to the yokes. The common pin positions of the commonly used gases for oxygen is 2 and 5, nitrous oxide is 3 and 5, air is 1 and 5. Now, presence and integrity of the pins should be visually checked before installing cylinders, as defects can make this feature useless. Now, pin index system, like you can see here, the yoke of the pin, it helps in preventing misconnections. The pins on the yoke must align precisely with the holes on the cylinder valve for a seal to form and gas to flow. It also ensures correct gas delivery. If the cylinder and the yoke are mismatched, the pins and holes will not align, preventing gas flow and ensuring the wrong gas is not delivered to the patient. Also, you can see a Bodoc washer. The pin index cylinders require a seal between the valve outlet and the yoke, and the seal is called the Bodoc washer. However, this system can be overridden if 2 washers are used. So this pin index safety system may not be 100% foolproof safety feature. However, all cylinders have this pin index mechanism that is used. The next safety feature we come across a color coding of the cylinders. In different countries have different national coding systems, which may not be in conformity with international coding. So personnel who work in different geographic areas may be confused, but in India, these are our color codes. Oxygen has a black body with white shoulders. Medical grade air is coded gray with white and black shoulders. Nitrous oxide is blue. Anthrax is blue and white in color. Here, medical oxygen, nitrous oxide. The next safety feature we'll talk about in high pressure system is the pressure relief device. Now, cylinders have exploded because of overpressure in them, either due to overfilling or misfilling. To prevent this, the ASTM standards require that all cylinders have pressure relief devices, which vent the contents of the cylinder to the atmosphere should dangerous pressures develop inside the cylinder. Now, there are two types of pressure relief devices. One is the rupture disc, where a predetermined pressure is reached. If a predetermined pressure is reached, a disc that guards an orifice ruptures, releasing the contents. This is the disc, and if it ruptures and all the contents in the cylinder are released. The other type of pressure relief device is the fusible plug. This is a thermally operated plug providing protection against high temperatures but not pressure. There is also a combination of these two which can be used. Now, the newer modifications have pressure relief valves which reclose after the dangerous pressure has been vented, thus saving the contents and not entirely discharging the cylinder. The next safety feature are pressure regulators. Now, anesthesia standards require that each gas be provided with a separate pressure regulator for providing a constant low pressure suitable for the machine from the variable high pressure cylinders. This helps in providing a smooth, constant flow of gas irrespective of fluctuations in pipeline pressures due to peak trough demands in the system. Now, some manufacturers adjust the output from the cylinder regulators to be lower than that of the pipeline pressure, so that even if the pipeline pressure is taken preference, even if the cylinder contents have been left open inadvertently. So these and some machines have two pressure regulators, some downstream of the flow meter. So this is how pressure regulators can be. Now, the next system we'll deal with is the intermediate system, which comprises of the pipeline, the master switch, the second stage pressure regulators, auxiliary gas outlets, and all the oxygen failure safe devices and flow control valves. Now, coming to the pipeline attachments, the probe for each gas supply has a protruding indexing collar with a unique diameter which fits into a Schrader socket assembly of the same gas. And then there are hose pipes. These are flexible, color-coded, and they have built-in reinforcements in the wall to make them kink-proof. So these pipeline attachments are unique. The collars are variable, but the probe is uniform. Now, each terminal unit that connects to the main pipeline system is equipped with the diameter index safety system, also called DIS, DISS. Now, properly engaged parts, they allow the thread to connect to each other so that the gas starts to flow. We also have something called quick connectors. They are other safety devices which allow correct attachments by using various combination of shapes and spacing of the components that couple with each other. Now, each gas inlet also contains a unidirectional check valve that prevents leakage into the pipeline system when cylinders are being used as the main source. Now, like you can see here, this is the pin index safety system, and this is the diameter index safety system. They have unique, each pipeline has a unique collar and a connection. Now, when you come to the machine end of the gas pipelines, the non-interchangeable screw thread connection to the anesthetic machine is unique for each gas. Now, each flexible hose ends in a unique fitting of a nut and a probe. This ensures hose connection specific to that gas. Now, the probe has a unique profile. So the probe which is at the machine end has a unique profile for each gas, which fits only to the specific gas to the machine. But the nut has the same diameter and thread for all gas services, and that can be attached to the machine when the probe is engaged. But the term non-interchangeable screwing thread is in fact misleading because the screw thread does not determine the unique fit. There is a one-way valve which ensures the unidirectional flow, and that is what helps the pipeline connect to the machine. We also have pressure pipeline indicators, and the anesthesia standard says that each pipeline should have a specific indicator. They have a color-coded dial, like you can see here. And in some, the working pressure zones have a special color for easier identification. Like you can see here, there are color codes, the pipelines, the hoses, the connectors, everything have different colors, and hence the safety features have to be maintained accordingly. Now we come to a very important part, the oxygen failure protection devices. Several catastrophes have resulted when the oxygen supply has been depleted, allowing administration of hypoxic gas mixture. So anesthesia workstation standards require that whenever oxygen supply pressure is reduced, the delivered oxygen concentration at the common gas outlet does not fall below 21%. So anesthesia workstation standards require that it has to make sure that there are safety mechanisms to identify this catastrophic event if it occurs. Now, the older anesthesia machines employed the Ritchie whistle, which is an audible alarm and cuts off all other gas supplies. Well, like when you see here, when oxygen gas flow, the pressure decreases below 200 kilopascal. This valve spindle is activated and a low alarm is whistled so that it is the anesthesiologist is alerted. And it also suggests that this audible alarm should be sounded within 5 seconds and that it should not be muted. The failure devices may decrease the supply of all other gases in proportion to the fall in oxygen supply. Pressure may decrease, or even total cutoff of the gases might be included, which may include air as well. So we have to be sure that there is an auxiliary supply in case this happens, so the patient does not develop hypoxia. Now, when oxygen pressure falls, there's a system called an oxygen pressure failure device, which decreases the other supply. Like if you see here, the oxygen supply pressure is 50 psig and nitrous oxide is also 50 psi. But when the supply decreases, there is a decrease in nitrous oxide supply as well. And here there's a cutoff of both the gases. But we have to remember that fail-safe systems don't prevent hypoxia mixtures. For example, as long as there is pressure in the oxygen line, because all these failure safety devices depend on the pressure and not the flow. So if another gas is going through the oxygen pipeline or the oxygen, it will still deliver that gas. Hence, they do not protect against hypoxic gas delivery, which may occur because of empty cylinders or misconnected pipelines or the wrong proportion of gases being dialed on the flow meters. So you have to be aware that these oxygen failure safety devices may still deliver hypoxic mixtures if the pressure in the pipelines are adequate. Now, there is also a second stage pressure regulator. This is an additional regulator in the intermediate system just upstream of the flow meters, so that flow is constant even if there are fluctuations in the pipeline pressure. These reduce the pressures to approximately 14 psig for oxygen and 26 psig for nitrous oxide if the pipeline pressures decrease. But it still delivers gas to the patient. The purpose of this pressure regulator is to eliminate fluctuations in pressure supplied to the flow indicators caused by fluctuations in pipeline pressures. Now, coming to oxygen flush, which we commonly use, this switch directs the high pressure flow of oxygen to the common gas outlet from the source, either the pipeline or cylinder, bypassing all intermediate meters and vaporizers. Now, to prevent accident, this is also called emergency oxygen. And to prevent accidental activation, these are usually placed, like you can see here, in a recessed setting and will deactivate as soon as the finger activating it is removed. But barotrauma and awareness may result from inappropriate activation of this switch because it delivers a higher pressure of 50 psi to the patient directly, and it's a continuous flow. So you have to be aware that it should not be kept switched on. So basically in the intermediate system, what you should do if you lose oxygen pipeline pressure? The first thing is open the emergency oxygen cylinder fully, not just what you do to check the machine, open it fully. Disconnect the pipeline connection from the wall. The oxygen alarm will sound to warn you of the change. If for some reason the oxygen analyzer does not warn of the crossover, the pulse oximeter will tell us, but the oxygen desaturation usually occurs only once the patient's functional residual capacity or the vessel-rich group are depleted of oxygen. So you have to be aware that pulse ox can be a late detector. Oxygen analyzer is a must in all these machines. However, considering that we are all from different backgrounds, some work in government setup where we may not have oxygen workstations, anesthesia workstations which have oxygen analyzers, there can be it can be difficult to identify how much of oxygen is actually being delivered. The next thing you have to do is ventilate by hand with the anesthesia breathing circuit rather than with the mechanical ventilator or a bag valve mask, because staying with the anesthesia breathing circuit means you can still deliver the volatile agent which is downstream to the oxygen flow meters. Now coming to the last system, the low pressure system, which comprises of the flow meters and the assembly, the hypoxia prevention safety devices, and the alternative oxygen controls. Now the flow meter assembly, potential or actual oxygen loss can happen if the flow meter, oxygen flow meter is upstream of the other flow meters, and this happened in the older machines because that time the oxygen flow meters used to be upstream of the other gases. So if there is a leakage in anywhere upstream of any other gas, now in this picture, if you see, the oxygen is upstream of air and nitrous. So if there is a leakage in the air flow meter assembly, oxygen can leak and a hypoxic mixture can be delivered to the patient. Even here, oxygen is placed between air and nitrous oxide, and the flow meter of air is leaking. So oxygen can deliver on either side, resulting in a hypoxic mixture being delivered to the patient. So the latest machines all have oxygen downstream to the other flow meters, and hence, even if there is a leak in the other systems, there is no leak of oxygen still is delivered to the sufficient oxygen is still delivered through the common gas outlet. Now coming to flow meters, anesthesia workstation standards require that only one flow control be provided for each gas, and it should be placed near the corresponding flow meter. So all these flow meters have these control valves and providing stops at the full on or off position so that excessive pressure may not damage either the valve seat or get disengaged at the full on position so that the gas escapes out. The oxygen flow control knob is the largest, like you can see here. It is the largest and it has a fluted profile for any additional and easy identification. So even if you're not looking at the flow meter, the feel of the flow meter still tells you it is oxygen. However, it's advisable that you always visualize the flow meters when you're handling them. Now we have other types of the types of flow meters. One is the traditional flow meter. This is how it looks. They have different lengths for each gas. And previously what was called the TOPS tube is now known as a flow meter. The tubes have anti-static coating on both surfaces, preventing the bobbin from sticking. And the bobbin is visible throughout the length of the tube. Now, in the traditional flow meter, the flow is mechanically controlled and displayed. There is a needle valve, an indicator float, and a knob. And when you rotate it counterclockwise, it comes into function. The next are transitional flow meters. Now, transitional flow meters, flow is mechanically controlled, but it is electronically displayed, like you can see in the Apollo machine or the Fabius machines. The flow meters are mechanically controlled, but there is a bar graph at the display, at the left side of the display in the Apollo meter, which shows the flow controls. And in the Fabius, flows are captured and displayed electronically through the common gas flow meter. So these are transitional flow meters. You also have electronic flow meters. This is, it's an odd way to do it because here you have to just enter the variables and the machine itself will calculate how much of flow is required. But we who are anesthetists, we are always used to setting a process. We are used to setting it like if I want 1 liter of nitrous oxide and 1 liter of oxygen to give me 2 liters of fresh gas flow at say 50% FiO2. I would like to set it on my own, but here the machine, you have to just give the desired outcome and the machine will calculate and electronically display the flows. So these are electronic flow meters. Then you have alternative flow meters. These are useful for attaching a nasal cannula or other supplemental oxygen devices. Now, if optional, they are strongly recommended as they are the only indication of oxygen flow if the computer display fails or in a power failure situation. So, these auxiliary oxygen flow meters are required. Then you have common gas flow meters and also scavenging flow meters. Now, scavenging flow meters are an indication that suction is adequate. It is mandatory with these systems and to avoid exposure to waste anesthesia gases, especially like the previous talk, if we are using low flow anesthesia, scavenging flow meters would be advisable. And the newer machines do have scavenging flow meters with the system. The next important topic would be hypoxia prevention devices. Mandatory minimum oxygen flow. Most modern machines have a minimum preset oxygen flow. In a few machines, this base flow is needed before any other gas can be turned on. And the flow is variable between 50 to 250 ml per minute. In machines which are equipped for low flow anesthesia, 50 ml per minute is the minimal flow. But most machines, it's around 250 ml. But yes, it depends on the manufacturer and the machine. The next hypoxic prevention safety feature is the minimum oxygen ratio. This anesthesia workstation standards require that the device be provided with a minimum of 21% of oxygen before any other gas can be used. So, but hypoxic injuries have happened in the past with older machines where it was possible to set oxygen and nitrous oxide flow independently, and hence this feature has now been incorporated in the newer machines, which helps to prevent hypoxic mixtures being delivered. Then we have the proportionating systems, mechanically, pneumatically, and electronically, which is meant to prevent oxygen concentration to be delivered less than 0.25 to the breathing circuit when nitrous oxide is in use. However, these systems also depend more on the pressure than on the flow of the gases. So in this proportionating systems, you have mechanical linkage and you have the electronic linkage. Mechanical linkage ensures that a certain set percentage of concentration of oxygen between nitrous oxide will either increase or decrease in proportion to oxygen. Above the set pressure percentage, above a minimum percentage of 21%, then the gases can be altered independent of each other. Once the oxygen reaches that, then you can independently increase nitrous oxide. Usually these devices only link oxygen and nitrous oxide, and that is a pitfall because air is not linked into this safety device. Here we have the link 25 proportionating system where there is 14 sprockets here and 21 sprockets here. And when the minimum flow is achieved, it links to the flow meter. And when you increase the flow of oxygen or decrease the flow, nitrous also links. But you cannot use nitrous oxide flow meter independently. Oxygen also will increase simultaneously. Electronic linkage is similar, but you have the feedback comes from a computer that constantly calculates the maximum safe limit of other gases that can be delivered. So the key points you have to remember that hypoxic guard systems can still permit hypoxic breathing mixtures if oxygen delivery is less than the consumption by the patient, like how Dr. Megha mentioned in her talk on low flow anesthesia. If the wrong supply gas is in the oxygen pipeline or cylinder, if there is a defective pneumatic, mechanical, or electronic component, and if leaks exist downstream of the flow control valves. And if a third gas is used other than nitrous oxide and oxygen, then hypoxic mixtures can be delivered in these patients in spite of the hypoxic guard systems. Now, the low pressure system also has pressure relief devices, which are usually between the vaporizer and the common gas outlet. And this vents the atmosphere in case dangerous pressures develop downstream. It's usually like a gas decoupling effect. Now, the common gas outlet, the feature. The ASTM standards require that it should be difficult for delivery host to be disconnected from the common gas outlet, and hence they have the standard 15 ml female slip joint fitting in with a 22 mm coaxial connector. The newer machines have more than one common gas outlet, and that can cause potential confusion, but the standards suggest that only one is functional at any given time. Now, I'll just give scenarios of an incident due to machine failure, how safety features mitigated the potential harm, and what are the lessons learned from past experiences. Now, in this case study, a 55-year-old male patient was undergoing an elective surgery under general anesthesia. Midway through the procedure, the anesthesiologist noticed a sudden drop in oxygen saturation from 98 to 85%, and an alarm sounded. The oxygen supply appeared normal at first glance, but further investigation revealed that the oxygen cylinder was empty and the pipeline supply had been accidentally disconnected. However, the patient, due to early identification, the patient did not have any hypoxia. Now, what are the safety features that may have helped? The first safety feature may have been the oxygen failure protection device, which automatically shuts off nitrous oxide supply when the oxygen pressure drops. Then the hypoxia prevention device, minimal oxygen flow system, which may have ensured that at least 25% of the gas mixture was oxygen, preventing complete depletion. The low oxygen pressure alarm. An audible alarm alerted the team immediately when the oxygen supply pressure dropped below a safe level. And backup oxygen cylinder. The team quickly may have identified and switched to an emergency backup oxygen cylinder, restoring normal oxygenation. So the lessons learned here are always perform a pre-use checklist to ensure oxygen sources are functioning properly. Ensure that both pipeline gas supply and your cylinder backups are available and checked before induction of the patient. And prompt response to alarms is critical in preventing hypoxia. We should not ignore alarms. There are many times we disable alarms, but many of the newer machines have the option that after 3 disabled alarms, the alarm will be a high alert alarm. This is a safety feature which is provided by the newer workstations. Now, coming to this, the second case study, a 45-year-old female patient was intubated for an abdominal surgery. So shortly after switching to mechanical ventilation, the patient's airway pressure began rising above safe limits. Within minutes, the ventilator high pressure alarm was triggered and manual ventilation became increasingly difficult. The team quickly identified that the APL valve was closed, causing excessive airway pressure and risk of barotrauma. So the safety features that may have helped here are the high pressure alarm system, which alerted the anesthesiologist to troubleshoot. The APL valve, once you release it, the excess pressure can be released and it can prevent lung injury. The pressure relief valve, it helped to release excess pressure when it reached a critical threshold, preventing barotrauma, and the fresh gas decoupling mechanism. So what are the lessons learned here? Always check the APL valve and ventilator settings before initiating mechanical ventilation. Monitor airway pressure trends continuously to detect early signs of pressure buildup. Ensure all staff are trained to recognize alarm signals and troubleshoot rapidly. So in conclusion of this talk of safety features, we should remember anesthesia machines and workstations are constantly developing in complexity, so newer problems might crop up. We have to be in tune with the new workstations, their safety features. The only way to stay ahead of dangers is to be on constant vigil. An oxygen analyzer and a vigilant anesthetist is the minimum mandatory requirement for providing safe anesthesia. With this, I conclude my talk. These are the key references. There are additional resources. Thank you.
That's again superbly done, Julie. It was really nice. I think you have, with a short span of time, duration, you almost covered everything. It's great. That's a really nice lecture. Now we'll take the questions. All the three are here. Shyvi, the first questions go to Shyvi actually. Dr. Muthukumar wants to know, what is that?
McCoy.
McCoy laryngoscope, a few points regarding its use and advantage over conventional scopes. I think the McCoy, she had covered the McCoy laryngoscope. I think they can be refreshed later.
But the second question, moderator sir, is can we use Macintosh for neonatal intubation?
Neonatal intubation. Can you use, Shyvi?
No, so the sizes available are
Yeah.
2, 3, and 4.
Yeah,
So that is basically for the adults. It's not for the pediatric groups.
Therefore, neonates, obviously no. Till infancy, I wouldn't advise. But beyond 1 year, maybe an expert can use it. But I think stick to Magill's. That is a conventional teaching. Take Magill's scope. Anything else for?
Sir, can I intervene?
Yeah, sure.
Because see, now even the recent edition Miller, it says even from the very beginning, even for newborn, because we are trained only in conventional laryngoscope. Not the straight blade was not available during our PG days. But even for that matter, I accept. I have never used a straight blade, Miller blade for a neonate or anybody. But it says if you go with Miller's blade, you have to lift the epiglottis. That itself will produce a vagal response. So already the vagal response is high in a newborn and a neonate. So it is always better because this Macintosh blade, the blade tip will be in the vallecula. So with that, see, routinely what I used to do, you place a fold of towel under the neck and you push the thing with your little finger. It is very easily, it will be seen. So we say the floppy epiglottis prevents, so we use straight blade. But if you press it with your little finger, it will very easily, it will be seen. Anyway, it is only the training. We are trained because we didn't have that. Even now, I am not having anything. I am having in my nursing home. Yeah, straight blade, but we are using only straight blade. This is only added point because people will be worried if it is straight blade is not available, then they cannot proceed. That's what I want to say.
No, basically, most of the pediatric anesthetists now they use the VLS, and VLS
that is right.
You don't get straight blades there. Therefore, it is not mandatory that you need to use a straight blade. Yeah, Dr. Shripad, that's it for Shyvi. I expected a lot of questions for Megha for the but there are hardly, there's one question, and Dr. Shripad has commented that in care station workstations, there is a facility to maintain the oxygen flow just above the required rate to a preset oxygen concentration. That's a comment. And again, Muthukumar asks, can you please explain the dangers of hypoxic mixture delivery when using nitrous? Okay, time has come for us to stop using nitrous oxide. It's nice to say that nitrous, when it was invented in or used in 1944, and it is still being in use. And when we said, ladies and gentlemen, this is no humbug for ether demonstration, ether has gone out of practice, but still, I think for environmental pollution and the side effects of nitrous oxide, we should stop using nitrous oxide. But there is a risk that hypoxic mixture can be delivered with air oxygen combination too, because the air contains nitrogen, and nitrogen accumulates. And there is always an argument, Dr. Muthukumar, regarding how much FiO2 should you be using and how much inspired oxygen should be reaching the patient. And I, as a safe anesthetist, would reverse, as Dr. Megha said, at 30%, I would change. If the FiO2 falls to 30%, I would increase it by 10% and I would reduce air by 10%, because I can't wait for 18 long minutes for the oxygenation to FiO2 to fall down, and then there is hypoxic mixture delivered and the patient has starts desaturating and then try to reverse. I will not do that. Though theoretically you can allow it to fall down to 21%, but please don't do that. Be a safe anesthetist, and at 30% you start reversing the oxygen and air combination. Anything else?
Here also I want to, sir, moderator, sir, can I answer?
Yeah,
See,
yeah, sure.
because just because you said about nitrous oxide to be discontinued, I recollect some 13 years back, two people attended a pro and con session debate. Nitrous oxide we continued. Another person said it should be discontinued.
Yes.
We discontinued Dr. Madhusudan Upadya and continued it is myself. At that time only he said the education is by Dr. Madhusudan and entertainment is by Meenakshi. So 12 years back he argued. Imagine now you are talking about green theater and xenon. He argued, but what is the thing? Even after 12 years, the same nitrous oxide is continued. That means intelligent people will be listened by the delegates only at a delayed time span. So it is happening. Anyway, it is a quick thing. Again and again, he is stressing that nitrous oxide to be discontinued to reduce theater pollution. He is fond of green theater. So it's a keen academician. So now even you may not be aware. Long back, he has talked about this. All right. Thank you, sir.
Thank you so much. Thank you, Megha, Julie, and Shyvi. It has been an excellent session. I think it is worth for the postgraduates to keep a copy of this, even for their exams and beyond.
It is good, really, it is good. I think we would have got tomorrow only we will know how many people attended, because we have to come through the backlink actually. And I want to say this is the first time we have allowed the lecture to go beyond the 7:40. This is the first time. Because it is going 7:30, the alarm will be coming. 7:48.
Really? Sorry.
This is the first time, even it has crossed 8 also. Then as it is a basic topic, we have left it as such. Then thank you, sir. Thank you, everyone. And to propose formal vote of thanks, I request Dr. Hema, our treasurer, to propose vote of thanks.
Thank you, sir. Good evening, everyone. I thank you all for your participation in today's episode, 12th episode on Puthukkotai Bhudan webinar series on anesthesia machine. Our sincere gratitude for our academic chairman, Dr. A.L.M. sir, for his guidance through the series. On today's episode, I thank the Department of Anesthesiology, Kasturba Medical College, Mangalore, for the impressive and elaborated presentation on anesthesia machine. Thank you. I thank Dr. Shyvi, postgraduate, Kasturba Medical College, Mangalore. You have given us detailed photographic presentation on video laryngoscope. Thank you, Dr. Shyvi. I thank Dr. Megha, Associate Professor, Kasturba Medical College, Mangalore. That was an elaborated presentation, explained in detail for a takeaway for the postgraduates and even practitioners on low flow anesthesia. Thank you, Dr. Megha. I thank Dr. Julie Misquith, Associate Professor, Kasturba Medical College, Mangalore. You have refreshed everyone's memory on the safety features of anesthesia machine. Thank you, Dr. Julie. I thank our moderator, Dr. Madhusudan, Upadya, Professor